yeah, let's get started. Okay, just some disclosures. Just know that I am receiving an honorarium for speaking with you guys today. Just a kind reminder to please no photographs of the slides with patient photos, videos, or patient information on them. They were given permission to use just for this presentation only. Again, just a little story short with me. I graduated from USC with my bachelor's degree in dental hygiene, went to dental school, met my husband. That's actually our 10-year wedding anniversary vow renewal that we just did back in September. So we did it with some best friends of ours. And I taught at USC. My heart and soul was like these mobile dental clinics where I've seen the worst case scenarios of, kids that had full mouth decay and they're like 3, 4 years old. And we all thought it was brushing, flossing, don't eat candy, but really it is more of a full body, like respiratory, breathing, airway, functionality perspective too, as to what contributes to all those high risk diseases I was seeing out in those type of clinics. A little story short, that's my mentor, Dr. Chelsea Pinto. She's amazing. She created the infant frenectomy protocol, and she came out with that earlier this year or so. So I've been under her mentorship, and she's been a gem. She's actually pregnant with her third baby right now, so pretty exciting. And I've been doing this since 2020, but I decided to come out with Tongue Ties with Love back in 2023. So it's been a nice journey to finally, accept what I do. It's hard to actually come to what I do. So it's weird to step out of dentistry and just solely focus on infant tongue ties and starting to understand function more to give these babies a good functional foundation from the beginning, and working with many collaborating providers like you guys. So this is part 2. We are going to be reviewing a lot. I'll probably be talking a lot. Again, I just try to put too much information, but I just want to share with you guys all that I have. So I might be going a little bit fast, but please just let me know any questions in the end. So just some review of some things that we discussed with the first one. Remember that the tongue is a very complex organ. It's made up of 8 different muscles, 4 intrinsic muscles, 4 extrinsic muscles, and they have all the other muscles of the head and neck connecting each other that's supporting the functionality of this tongue, okay? The tongue does have more functions than the heart itself. The heart's job is only just to pump blood, but the tongue, if it's so restricted, it really does impact functionality in the whole body. Remember, tongue movement with what we're looking at to help with feeding, it goes in so many different directions. It goes in, out, up and down, side to side, move in a wave-like motion. It cups, it grooves, it flips, it curls, it rolls. So we need to have good functionality of this muscle and other supporting muscles that help with the action of feeding. My tongue, different directions, okay? And we also have to be mindful that, bottle feeding does use less muscles and action needed to get milk. When we're breastfeeding, it's pretty intricate where you need to create like a negative pressure to basically extract that breast milk from the breast. Where bottle feeding, you can literally turn any bottle upside down. It's just like a little hole and just milk just dripping out of it. So that's why babies are either going to wait for the bottles or they're having a difficult time on the breast. Babies are going to have an easier time for sure just wanting to drink from that. But if a mom's desire is to try to breastfeed, we definitely want to encourage and support that. So we really need to look at everything as a whole and give them, all the different aspects of support. It's not just all baby, it's a dyad. We need to look at mom's breast. We need to look at mom's history. We got to look at mom's medications of what she's taking. We got to look at baby's anatomy. We got to look at how birth history was, positioning in the womb. That really does overall impact the feeding relationship of the dyad. So my main thing about like the signs and symptoms for you guys is like when you really see these red flags from the document that I gave you guys, if you guys are noticing any of this, even if your intake forms, I encourage you guys to add these symptoms in there and ask your families, are you experiencing any of these symptoms in your babies? You could write yes, you could say sometimes, you could say no. I like to use sometimes because babies feed differently depending on time of day. If they're hangry, if I'm hangry, I'm not going to function very well. Also, what position are they in? do they have shoulder dystocia? Do they have torticollis? There's all these things that can impact it. So are these symptoms consistent with every single feed, or is it just sometimes? It really does share a lot of information. And so I really stress in the first presentation is not just about how it looks. The anatomy is one side of it, but it's also what's going on functionally. And so again, lipsters versus sucking pads, we is common to see these type of presentations, but usually after 2 weeks or so, we want to see these start to disappear. And if they're still around or they're two-tone colors, what's going on? Look at the actions of the lips. Are they overusing it or is it more passive? Yes, white coating of the tongue. It shows that probably the mid part of the tongue is elevating as well, but what's the reason why? I don't just jump to tongue tie right away. I'm looking at what is muscle tension, what is neck mobility, what's not allowing that tongue to move, not just anatomically. Let's see. Okay. I don't know if you guys remember this photo, but yeah, this was my daughter, the left photo. You can see she's not having a good seal or good flange, but right after the procedure, you can see that nice seal, that nice flange right there. Not sure if my videos are going to work, you guys, just FYI, because there's a lot of memory that this is taking in, but this was not yes, no. Did you guys hear that or no? Not really. Okay. Let me see something, you guys. Sorry. I want to show you guys the different sounds that you could hear, but I don't think that's gonna work. I try to make these videos smaller just so it doesn't freeze up, but I don't think that's happening. Okay, everyone froze. I guess I learned that my videos I have does not work. Can you guys hear me? Did I freeze up to you guys? I didn't freeze. Okay, you guys froze for me. Let's see. Okay, let me see if I can get out of this. It is frozen. I am sorry, you guys. Let's see. Let's get out of this. How do I get out of this? Let me go. Let me click here. Okay. I think I learned I can't do videos. Are you guys good? Like, give me a thumbs up or something. Like, I think videos just slow my presentations down, and I think they're just too big in memory, and I'm not very good in how to make them smaller. Give me one moment. Sorry, you guys. It is, you could probably see from the share screen, I don't even have a mouse right now. But anyways, those are some, signs and symptoms that you guys could easily spot when families connect with you. Is it aerophagia or is it air-induced reflux or is it actually true reflux? Earlier at this younger age, it's scary to me when I see pediatricians just start, handing out these anti-reflux medications to these young babes because number one, we have to remember their guts are very maturing at this time. Their guts are a lot more sensitive. And also if we don't have good functionality, you're going to get air induced into that area. So I wouldn't just jump into it. And just remember that acid reflux medications on babes, research has linked these medications during infancy, that these kids would have a higher risk of bone fractures later in childhood. So we can't just start giving these medications out like candy. Breastfeeding for moms, any of these moms have any of these concerns, nipple pain and damage, lipstick shape, things like that, that is a concern to get this assessed. What is going on with baby? Why are they compressing on the nipple? Why are they having a shallow latch? And like what I said, other factors that impact tongue function. So we really do look at the whole body because we know babies don't just feed with their mouths, they feed with their whole body. I now have this feel that I tell families, what I'm looking at is something called a frenulum that's underneath the tongue, the lips, or inner cheeks. They're normal anatomical structures. And what this normal anatomical structure is made up of is something called fascia, which is something we discussed shortly, like on the first presentation. And fascia is a type 1 collagen that doesn't stretch. It encases all the muscles of our body like spider webbing. So we know that there's a tongue to toes connection. So there's not obviously there's always going to be some sort of trauma to the baby's body during birth, whether it's vaginal or c-section, so that tightness and tension of how hard they work to get out onto earth's side, there is going to be some like tension and tightness in those areas, and like any asymmetry in the body does impact their feeding. And so a lot of times too as well, I've noticed a lot of times families will always tell me, like, the lactation specialist at the hospital said everything was fine, everything was great, and then now it's not. It's like a couple days later or a week or two later, now it's just horrible, but they told me it was great, so what's wrong with my baby? I think we have to be mindful and start reminding these families that, hey, things look great now, but that doesn't mean things can't change. It reminds me also of that time I got into a really bad car accident. I felt great. I was like, I'm not going to go see anyone. And my dad's like, you're going to see someone. You might feel that pain and those issues a couple of days later with that impact. And did I? Yes, I did. So I think that's the same concept as well, that I want us to be more mindful of what we say to families. I know we want to be encouraging, but I think we need to set the tone too as well. Make sure that you're seeing a lactation specialist, a personal lactation specialist, in a week, and then maybe at 2 weeks out, to reassess how things are going and how baby is adjusting to being here on Earthside with us. They never had to use these muscles before, ever. They just got fed through an umbilical cord. They were happy as a clam, and now you're making them use certain functions that they had to learn to do. So I really encourage that, because a lot of times, like, that's all I hear. I only saw the lactation specialist at the hospital because they said everything looks perfect, everything's good. But I think we need to set them up to say it's great to still get follow-ups even afterwards. Trauma. This is trauma in the mouth. So a lot of things can impact feeding. Torticollis, plagiocephaly, any asymmetries. So of course, remember that basically, first step, no matter what, for families, we want to make sure that they're getting lactation support. It really is the most important key. And I'll talk a little bit more about collaborative care, but if you notice that baby is a lot, just very tight and tense and very dysregulated, I really encourage you guys to automatically send them for some sort of body work, like chiropractic care, craniosacral therapy, just to help unwind that fascia and those muscles to really help promote functionality. And so that would be ideal and amazing. So just remember how tongue, lip, and cheek ties are diagnosed. There has to be a functional limitation in addition to an anatomical finding underneath the tongue to meet the criteria of a tongue tie. Okay, but be mindful. Remember, everyone has something called a frenulum. An assessment or diagnosis of a tongue tie is not just by looking. You have to get more in depth of it. You got to feel, you got to see, how is it functioning, not when they're crying and when they're upset, but when they're nice and calm. Assessment tools. There are a lot of different assessment tools. These are the most common ones: Kotlow, Carrillo's, Hazelbaker, Martinelli, and Dobrich. But we have to be mindful that there is still a lack of standardization, still unclear. Individual variability in the location of the lingual frenulum on the ventral tongue surface formed the basis of grading system developed by Kotlow and then later adapted by Carrillo's. This created a dilemma regarding when a lingual frenulum's appearance can be considered normal, and potentially drives an international trend for increasing rate of diagnosis of ankyloglossia reported in Canada, the US, and Australia. So we have to be mindful of this, that we're not just calling everything that we see a tongue tie just because they're having issues and issues with function. These are a lot of common terminologies that we use. And so we need to start utilizing the right terms to help decrease that confusion and to start to promote more standardization in what we're saying. So, a frenulum, a frenum, a frenula, those are plural. Again, we all have one. It's underneath our lips, our cheeks, underneath our tongue. They're normal anatomicals of what we see. I tell families it's kind of like an anchor to a boat, it's like an anchor to that tongue. It needs some sort of stabilization for that muscle to be moving in different directions. TOTS is a general term to hold everything tethered oral tissues. But I personally don't like to use that term TOTS because it could get really confusing. Another term that people use is oral restrictions, more layman terms. You have a lip tie, cheek tie, buccal tie, tongue tie. Um, but you see those terms of lip tie, cheek or buccal tie, and tongue tie when that is coming up towards a diagnosis, not just because like, oh, looks like they have a tongue tie without even assessing any functionality of things. Okay. So we have to be mindful of the terminology that we use. Ankyloglossia, that is the medical terminology that we use. Ankylo means stiff, immobile, glossia is tongue. And the procedures, frenotomy, frenectomy, frenuloplasty. Of course, with babies, we're using a frenectomy. And so a frenectomy is like a surgical incision to cut the frenulum in half and it blossoms up to make a taller new frenulum. I tell families a new frenulum will always form. We do not get rid of frenulums or anything like that because, again, we need a frenulum there. Our goals of the procedure is not to eliminate the symptoms. Our goals of these procedures that we do for babies is to provide mobility to these muscles and to these tissues. And then it does have an indirect impact on functionality. But sometimes we need that additional support to work on the function of the muscles to reteach and relearn them, which is why it takes a collaborative care team. The other term frenotomy is to cut into. Frenuloplasty is more like reshaping, more surgical repair, placing stitches. So for kids and adults, I'm placing stitches. It's definitely more of a frenuloplasty because I could approximate the tissues. So you have a better outcome with how the wound is healing because they're touching each other where I want it to be. A release is layman's term for frenectomy. A revision. This is where I see a lot of confusion with different professionals and the families. A first tongue tie procedure is not called a revision. A revision for us means it's a second procedure, not an initial one. So I have families come to me, oh, someone came and sent me and referred me to you because I need a revision. Oh, you need a revision. When was the first time you had the procedure? Oh, we never got the procedure done. That's why we're here for a revision. So I don't use those terms because I want us to start that movement to start to use the correct terms. So again, a revision is maybe because we're doing it again because of the incomplete release by the first doctor. We're doing it again because we still didn't get the best outcomes. And of course, that's a whole other type of lecture of like when to do like a second release and when is it warranted. And another terminology that you'll like to hear, that a lot of people hear, is like a snip or a clip. That is not a laser frenectomy. That is like straight up with scissors. So completely different. It's more of like a partial release. And so just be mindful of these terminologies that we are using. I'm definitely very mindful of it. When I tell families, I don't like to really use the term revision in general. I'm kind of eliminating that from my terminology because you don't want to, I could tell families get freaked out when they start hearing like reattachment and revision. And so we just had to promote that. The purpose is that we're getting a tall functional frenulum that's more flexible, and we had to see over time how is that new frenulum impacting that baby's functionality, and do we need a touch of, I say touch up release in the future. I feel like it sounds a little bit more gentle. This is just me coming up with my own ways of explaining this to families. But yeah, some recommendations of these terminologies and terms. Let's see. I want to share this case study with you guys. I threw in like 2 cases, I believe, in here. This case I want to share with you guys because really it just shows about like the support of everything and timing with these families. Of course, the family comes in, we need a revision. There is no revision. They came to me with no lactation education. Midwife definitely understands what she's doing, but she was really pushing them, you need to go get it done now, ASAP, right away. I know mom's in pain, but we know that there is some sensitivities in the beginning. As you can see from my intake form, she had moderate pain and everything like that. But I really push for them to get lactation support right away first before doing the release. And I just wanted to show you guys, the history and timeline of this, of like when we don't prepare these families in the right way, or they just feel rushed, they feel like that what I do is a magic fix, and we're not all on the same page with the other providers. But you can tell that this frenulum is very short. You can see these little balls elevating. Those are the salivary caruncles. They should be more relaxed when you're doing your assessment. You want babes to be very relaxed when you're elevating the tongue. You don't want them to be crying, because no matter what, anyone cries, even adults, everything stiffens up. Okay, everything will stiffen up. So that's not a true assessment of anything. But I want to show you, you can look at the dates, and the healing wasn't ideal. This family was not ready, but they got lactation support, everything else overall seemed pretty good. They were tired. They were definitely, I felt, over aggressive with their wound care stretches, which is why it healed a lot slower, because there's no other concerns. Circumcision healed well and nicely. And then finally, I saw them at 10/24, which is close to 2 months, just under 2 months from the initial procedure. And you can see that, yeah, it healed a little bit thicker, because see, these salivary glands are more relaxed into the floor of mouth. Mom is having a better time now feeding. It's just those initial things. It just makes it very, very difficult, So we had to just be mindful of timing with all that. I guess I should have put this in the timing part. Sorry, you guys. I forgot why I put this for the assessment part area. But, again, like, you can't diagnose this from photos. Like, if you look at 10/24 and be like, oh, hey, like that needs a revision. I don't know. Did you ask about functions? What's going on? What do we do? And so we really have to keep on reassessing these babies every single time we see them from different eyes and perspectives. I'm just going to go over a little bit of all the different classifications, but I'm not going to go into details of how to do them or anything. I'm also not a lactation specialist. Okay. I have my ways of what I've learned, but number one, Kotlow was one of the ones that first came out with a free tongue tie measurement, but just know that this is only for 18 months to 14 years old. Babies under 18 months, we cannot use this. But it's just measuring from the tip to the top insertion of the frenulum. My concern about this is just like, okay, you say like these measurements, it is like mild, moderate, severe. I think mild, moderate, severe, I don't use those terminology, because it's just kind of like a restriction is a restriction depending on what's going on from a functional aspect. We also have to be mindful that the tongue doubles in length, width, and thickness between birth and adolescence, and grows considerably beyond this period. So this is how the Kotlow one is used. I use this for my older children and adults for a different measurement, but there's so many different layers and so many different viewpoints you have to use when you're seeing kids and adults versus like babies. For babies, this is what Carrillo's adopted, was the Carrillo's classification. I share with families, and I share this with every single family. I'm going to show you the anatomy of what I'm looking at. And I take my puppet. I say, you're looking at a side profile. Where's the blurriness? Is that frenulum attached to the tip where there's no movement? Is it farther back where there is more mobility? What's the tissue type? Is it tall, thick, thin, muscular? Is it flexible, inflexible? Is it short? Is it thin? So there's so many different variations, I feel, of normal anatomy we have to respect and understand, and how each frenulum is so different for that person and that baby. And so again, there's definitely room for growth on top of the Carrillo's classification. But this is literally something that I show families so they kind of understand like what I'm talking about when we're looking at mobility of the tongue and the muscle. Where we have a Carrillo's one, where you can see I tell families we want the tip and mid part of the tongue to have good range of motion to do all those different functions, in, out, side to side, up and down, and move in a wave-like motion. The genioglossus muscle right here is a very important structure for me when it comes to the procedure. That is my stopping point, okay, for any procedure that you do. And also too, when you look at Carrillo's 4, that's also the farthest a frenulum can go, all right? And then now you have these different definitions, how Carrillo's 1 is very thin and elastic, attaches to the tip of the tongue and to the alveolar ridge of the jaw right here, and forms like a shape like heart, okay? A Carrillo's 2 is similar like a 1, but it's not to the tip. It's a couple millimeters behind the tip of the tongue. A Carrillo's 3 is thick, fibrous, non-elastic, and attaches more towards the mid part of the tongue and to the floor of the mouth right here. And then this one, Coryllis 4, the frenulum is not seen, felt, more fibrous, submucosal, thick, shiny attachment from the base of the tongue to the floor of mouth. Okay, so you can see and respect these different anatomical variations. Okay. But for example, like a Coryllis 1, sometimes when I've been doing this for, I guess you could say, like almost close to like 3.5, 4 years, that I've learned to see all of these different frenulums that I see do not match up specifically to the classification. So I think it's just showing us too to just be more mindful, not to just get stuck that they don't fit into this box. You can see right here with these right photos, like to me, this one up here, yeah, it's a heart shape, it's to the tip. That frenulum does not look elastic at all. It looks very short, is very thick. Same with this one right here. Okay. So we can't limit the variations of anatomy to that specific type of classification. Location of attachment may be correct, but the description does not match it. Same thing with like a Coryllis 2. You know, this frenulum right here is not to the tip, which is right up here. It's very short. It's definitely not elastic. It's very, very tight. Okay. So I think being mindful of using these classifications as a guide, but also having logic too as well, is very helpful when we're trying to guide these families. This was a fun one. How would you classify this frenulum with the Coryllis? There's two frenulums there. That was actually a pretty cool case. It was my first one I ever seen double. I was like, okay, I had to make sure I put this on there. But you have one like frenulum that's closer towards the tip, and then you have one that's farther back. And this black area is actually my glove. I kind of wish I was wearing blue at the time, so you could probably see it a little bit better. But this was a very interesting double frenulum that I saw. Never seen anything like that. This family drove very far to see me. I didn't have time to put their case study up, but I do tell families that those are restricted to the tip or close to the tip, to be mindful that sometimes we need a touch-up release in the future. There's so many different things that so many different factors that impact the way that the new frenulum will heal, that we have to see and assess how functionality is going. Okay. So I warn these families to know, because sometimes families think, oh, yeah, you just do it once and it's perfect and that's it. It's like, well, there's so many things that impact the way it heals. How is wound care? What's a head and neck tension in the body? Any asymmetry? What's our mobility? How's tummy time going? So many different factors impact wound healing. Did it heal a little bit thicker? Yes, it did. But did it move farther back towards that muscle, the genioglossus? Yes, it did. And there's so many great changes from the initial consultation questionnaire to like the second follow-up questionnaire, that mom is very happy and just seeing a lot of great changes in functionality with what's going on, that she's able to breastfeed now. So it's just allowing them to remember, like, hey, just keep in your mind, as functionality gets more complex, we have to keep on reassessing how is this new frenulum functioning for them. Okay. Hazel Baker, Martinelli, those are the only two tools that have undergone validity and reliability testing. Okay. Hazel Baker for lingual frenulum function. You could tell that like with these two types of assessments, it's basically answering the questions, adding it up, and seeing do they fit into this assessment of recommendations. Again, use it as a guide, but I wouldn't just completely like make it make sense. You know, it's like if you add everything up and it says there doesn't need to be a release, but then we're still having all these issues, make it make sense and really encourage them. Let's just get an assessment. Let's just create a collaborative care team from different providers to make sure we're seeing it from different aspects, okay, with feeding. So again, you're looking at lateralization, lift of the tongue, cupping of the tongue, the peristalsis, you know, non-nutritive sucking that you're trying to encourage. Also too as well, what is the state of this baby when you're doing these assessments? Is this baby mad and pissed off? Do they have a sensitive gag reflex? Maybe they can do peristalsis on non-nutritive sucking, but maybe they have a dirty diaper, you know, maybe they're hangry, maybe they're very tired. So again, just being very mindful at the time that we're doing these functional assessments. What's the extension of the tongue, snap back? There have been times where I actually ask the moms, I tell the families to please feed them before you come in. But sometimes that doesn't work. And sometimes, you know, you have those babies that don't like being in car seats either. And so they're very pissed off. So we really want to also just calm their calm their nervous system down. Okay. Martinelli, she has more pictures to help guide you on how to answer and do her assessment those different ways. Has some similar things with like tongue movement, sucking rhythm. And again, you're adding things up to see, okay, should a release be indicated? Should we reassess, or things seem normal? Dobrich, not as detailed, okay, but definitely takes into account like some certain anatomical features where it's like, hey, we should look further into this, okay. But the main takeaway with all the different assessment tools that are out there, remember that a lot of this assessment isn't black and white. There's definitely a lot of room for error. It is very subjective at times too. But we shouldn't just be basing everything on like the tools or whether or not enough boxes were checked off to justify or not justify a procedure. Also, too, remember who you're working with. If you know a doctor who truly understands what's going on and you have a good relationship with them, let them know your assessment. I don't think this baby needs a release, but I want your opinion to know. Baby family's not ready for release. They don't want to release. They just want more information. I really respect when I get that information so I know what direction and what way I can help guide the families to make them feel comfortable and safe, and knowing that I'm not going to just push for anything if I feel like, a baby needs a release, I respect it. So give them that feedback to the doctors that you work with. And again, it definitely takes a collaborative care team. Babies are not robots. Okay. We really need to sometimes reassess them multiple times to make sure. And I also do tell families as well, especially when it's like a Coryllis 4, it looks like there's good mobility, but things aren't just adding up. And, when we have good mobility of the tongue, what are we doing to help support functionality, to help improve it? You know, are we doing oral motor exercises? Are we seeing body workers to make sure that there's no asymmetry, tension, or misalignments in the body that can impact the functionality of what I'm looking at? A lot of those things can also change the anatomy of what we're looking at too as well. So if we know we have issues, but we know clinically it looks like there's good mobility, let's support that by getting them to the right people. Whether you're a lactation specialist that does have that additional training with oral motor exercises, follow up with them, share with families what you're looking at, what you're looking for, and to reassess again a week later. If you don't have that experience or you don't feel comfortable doing, which I completely understand, find someone within your team or connect with me. I could definitely connect you with some other providers like occupational therapists, who really have, or even feeding therapists, speech language pathologists. I know some of them are working with babies too as well. Like they understand more the functionality of things to help retrain those muscles of what to do. I guess I'm just kind of curious, raise of hands. Has anyone heard if baby has a lip tie, there's no tongue tie? Has anyone heard that? Okay, that's good. If baby has a lip tie, if baby has a lip tie, there's a tongue tie too. Okay. I know Dr. Bobby, yeah, okay, so a couple of you guys raise your hands. So that is not true. Okay. The doctor who said that actually took that back, and we have to reassess from different aspects. Okay. We can't just put them into that box. And I see it all the time online. Oh, baby has a lip tie. There's definitely a tongue tie. And I do my assessment. I was like, tongue looks like you have great mobility, but the lip looks really, really restricted. Okay. Different classifications for the lip. There's Kotlow classification. Santa Maria, which is the next slide I'll show you, will show that, on the Kotlow classification system fails to be reproducible, and so has poor reliability. And to be honest, I've never seen a class 1 ever, okay, on a baby. Never seen this, okay. Have I seen maybe something similar like this on adults? Yes, because what we do know, the jaws grow in different directions. We know that the frenulum can move higher up. Okay, still needs to be more research on it. Kind of hard to follow, but yeah, I've never seen a class 1 before ever. And so that's why I'm more for the Stanford classification. And with the research that Santa Maria did back in 2017, showed that 83% of babies have a labial frenulum that inserts along the mid-attached gingiva, which is photo 2. Okay. Again, 83% of babies. That doesn't mean we're releasing 83% of these babies. Okay. So that's why you have to understand that it's not just based on appearance alone, which is what Santa Maria is saying. Stafford 1 is basically the bottom insertions higher up into this mucogingival area. Okay, more in the lighter pink area. You can see Stafford type 2, the insertions at the gum ridge. Stafford 3, it basically wraps around. The Stafford 3 is when you really see the notching in the gums. Okay. But yeah, the release of the superior labial frenulum based on appearance alone cannot be endorsed at this time. It really can't. And it's also, again, you're feeling these tissues when they're not crying. Is it soft? Is it very hard? What's the orbiculus oris muscle feeling? Is it very firm and overworking? Because if that's very tight and overworking, that could also change the anatomy of how that frenulum feels too as well. So a lot of times I really want to make sure that we're eliminating other factors that's impacting the soft tissue anatomy. Um, was this last year? I think this last year or beginning of this year. Many of these tongue tie providers that are, creating the pathway of research to get more information finally came out with, how to look at buccal frenum, aka the cheek ones. And so there's definitely more research, but at least we have like now a classification, okay, where the frenulum, is it in the mucosa right here? Is it at the attached gingiva? Or is it more on the alveolar ridge? You can see like an indentation right here. For me, I have released some of the cheek frenulums, okay? I have, but definitely with more guidance from the functional aspect, okay? Sometimes what we've noticed too as well, when we release the lip, it does relax the cheek areas. And definitely, yeah, I feel cheek frenulas like everywhere. And then I do notice that if they're overusing those muscles, those get really, really tight. And I also do notice too, if we're releasing the lip, those areas soften up because they're all interconnected. Okay. So it's definitely under the guidance of OT or lactation specialists. They're really watching feeding for longer periods of time than I am to, release these cheek ties. But it's definitely like more research is still needed. Again, the job of the frenulum is to support the tongue and limit its movement, which is why we all need to have one. So with my assessments, I know these babies are a little bit older. I haven't had time to find like the younger babes, but I'm putting them in different positions. I want to make it very fun and playful for them. I'm looking in the mirror so I can see exactly what my finger's doing and maybe what the baby's doing in lateralization, moving the tongue around, sticking the tongue out. Babies like that bouncy feeling too, so if that helps calm them, you could get into their mouth. If baby has more sensitivity with fingers or anything being in the mouth, that's already a red flag for me. Like, okay, we got to calm the nervous system down. We got to get this baby used to having fingers going into the mouth, especially if we're like preparing for a procedure. But, you really want to make sure that they're in a very nice, calm state. I'm going to go really fast now, but again, you can't diagnose from photos. Um, some are very obvious. Yes, some are very, very obvious, but some are not. And also, we have to be mindful, how hard are you pulling on those tissues when you're taking those photos? You could pull on anything and make it tight. So you really want to make sure that you're getting a true representation of what's going on. Just like this photo, Prince William. I don't think he would be flicking people off. Okay. And so again, photos are just perspectives. Is that one moment in time from a different perspective, and then we see a different perspective, he's not flicking anyone off. It's just, the angle that you're viewing it at. So we do have to look at it from different perspectives and angles. Just some things I found on Facebook and online. Does it look like, does it look like, does it look like, does it look like, does it look like a tongue tie? Does it look like a lip tie? I get people who send me photos, like I will make observations like, yeah, that frenulum looks very short. It looks like it's to the tip. Definitely, let's go in. Yes, obviously that is a restricted tongue. Again, those are the very obvious cases, but these lip frenulum, like what Santa Maria said, 83% of these babies will have an attachment to the gum ridge. Look how tight these parents are pulling that lip up, especially lip frenulums. I'm like, I don't know. I need more information. I see a frenulum. I don't see a lip tie. I see a frenulum. What's also the functional issues and concerns that you're having too as well? Okay. Same exact thing. This is a doctor that responded, wow, that is quite a lip tie. I'm like, oh, really? I see a frenulum. Okay. We have to be mindful as professionals to not just say it straight out, because it really does create a little chaos for a new mom that's having issues and thinking that sometimes, like, releasing it is like a magic fix right away. And sometimes it's not. Also too, again, photos. I love taking photos of like the babies and trying to get a good replication of the tongue positioning. So of course, this baby was crying really hard. And so you could tell before the release, this frenulum was short. And then after release, I try to catch at the same moment when like the tongue was up and high. So they're very similar of what represents that. You can see that that tongue lift, even though you are using other muscles to lift it up more than what it normally should, it's a good representation of just trying to be very consistent in what we're looking at. Okay. And so again, the frenulum's appearance is a result of the effect of tongue movement on the tissues of the floor of mouth, which is what Mills said, Nikki Mills. It stiffens to stabilize the tongue and at the extreme of its range of motion. This is my daughter. That's when the tongue was, muscles were contracting, and that's exactly her too on the right. Her frenulum looks different depending on what's going on of the action of the muscle. This is when she was crying, and they take a breath and they relax. That's how that frenulum looks. Okay. So that's why we can't just be diagnosing just straight up of what they look like and what photos look like. Collaborative care, you guys. Oh, I hope this video plays and doesn't freeze me. This is what collaborative care looks like to me. Let's see. Okay, I hope it played. It's a Ferrari F1 pit stop. Let's see. Can I go to the next slide? Next slide. How come it keeps playing? Okay. These race car drivers and their whole team, they work so effortlessly together to basically change all four tires in under 4 seconds. Like it's amazing. And it takes a lot of teamwork to really help support that driver. And that's how I see collaborative care as like, a whole team to support the racer right here. We all win when we work together. So for me, the mother baby dyad is the driver, the midwife doulas right here is on the side, medical team, nurses right here. And then at different tires, you have chiropractic body work care right here. Sometimes physical therapists are needed, lactation specialists, occupational therapists or feeding therapists. And I feel like that's me. That person's releasing the car saying you could go and drive and race. And that's kind of how I feel when I'm the dentist. Like, okay, are we going to release or not going to release? What more information do we need? Do we have a collaborative care team to make sure that the outcome of it is not just a new frenulum that's flexible, but for me, the procedure outcome goal was a progress of functionality and what's going on. And so again, it takes a whole collaborative care team. This is, what I sent to you guys last time, but definitely a lactation specialist, number one, lactation specialist. And if lactation specialists don't feel comfortable about tongue ties, I really encourage you to really take more courses because I know there are, especially like I think it's gold learning. I have a lot of colleagues who have lectured for gold learning about oral restrictions and how to help the dyad from a lactation specialist point of view. But this collaborative care team also helps us determine timing of release. Okay, timing of release is really, really important. For me, sometimes if we go too fast, it could impact the way that it heals. Okay, and you may not get the fast results. And also, too, if we're in a good time and space to work on functionality first, you're going to get faster results after the procedure than a lot later. I do tell families consistency of these changes with a good collaborative care team. You're looking more at like maybe 6 to 8 weeks post procedure. Okay. It's kind of like you're not going to ask someone who broke their knee to go running and sprinting a week later or 2 weeks later. You need to give that time for the body to heal, to adjust, to strengthen, tone, and coordinate these muscles so everything in the whole body can work in harmony together to optimize function and feeding. Okay. Timing of release is also important because we also want to use the primitive reflexes to our advantage. What we do know is that they do tend to integrate as early as 8 weeks old to 12 weeks of age, but that still doesn't mean you can't not do the procedure after 12 weeks. It just might mean it's a different care plan to prepare for it. Okay. But that's why the sooner that we get them assessed and the sooner we get them a collaborative care team to take advantage of these primitive reflexes, babies change very, very quickly. Just 1 week of oral motor exercises, like they see those drastic changes. And I tell families, like, you will see change. You don't need the release right now, but with the oral motor exercises, you will see that progress to make the outcome of the procedure faster. Okay. But again, there's lots of things to consider for delaying a release, dysregulation. They're always in fight or flight and everything like that. And you're doing these wound care stretches. That's going to impact the way that my wound is going to heal. Any asymmetries in the body, signs of any oral sensitivity or aversions. I tell families it's like a canker sore underneath the tongue and lips, and you have to do daily wound care stretches. For me, my protocol is 3 to 4 times a day. I know other doctors are like every 3 hours for 2 weeks. So that's around the clock at night, which is a little bit overkill, I feel. It's more about the quality of the wound care stretches, not necessarily the quantity. Okay. But we have to be mindful of that sensitivity because, of course, a parent's goal and fear is that I want my baby to eat, but my baby's not eating. So you don't want to keep throwing more things at it to kind of increase their fear. So you really want to help prepare them. Is there high tone or low tone in the body? That's really important because, again, the core of the body helps support the head and neck functionality. If there's like low tone in the body and everything like that, an OT shared with me, a good friend of mine was like, that tension underneath the tongue is actually helping that baby while they're strengthening, toning, and coordinating those other muscles. Okay. So sometimes doing a release too soon can also make things even worse if the baby's more low tone. We tongue movement, still healing from a prior release, parents emotionally and mentally not ready. That's a big factor for me. Okay. If they don't have the support and they're too scared and too emotional to go in there and do the wound care stretches, the patient's my baby, not the mom. Okay. So if we don't have good support for the baby during this healing time, which is the first 2 weeks, I tell families it's not the right time. Even though I know you're struggling to feed, but if you're not going to be able to do the wound care stretches, we're not going to get a great surgical outcome of how the new frenulum will heal. There was actually one time, one family, they're ready, and all these emotions came up, and I told them, I'm going to say no right now. I'm sorry. I'm going to say no. Okay. They admitted to me too as well. Another family's like, well, we're not going to do it. We're not going to do the wound care stretches. We want to just get it done. I'm like, well, then I'm not going to do the procedure. I'm sorry. I'm not. Okay. So I really do take that very seriously about what's a parent's emotional status and what help. I had families that bring in their nannies. I'm like, great, I'll show the nanny how to do it. Okay. I've had families that came in with their lactation specialists, and some of these lactation specialists have accommodated families, which I encourage and love. I'll show that lactation specialist how to do it. Okay. So, yeah, if you guys ever want to shadow or things like that, please contact me and come on in. Like, we want to get all on the same page together to really help the families. I have a video. I'm very scared to play it. So we will go to the next one, but it's just showing a tight baby versus a not so tight baby. This baby was very nice and relaxed when I was moving the head and neck area. This baby was just curled up into C position, just into a tiny ball. These two babies were actually seen on the same day and actually very similar attachments of the frenulum. This baby, I did same day release. This cute baby and this cute little like tangerine outfit, nope, didn't release on same day. We did some body work, released that tension and everything like that. And we had definitely a better healing outcome for sure. How can I skip the next one so it doesn't play and freeze up my computer? Okay, there you go. Oh, okay. So again, each family might be different. That's why I'm like, it's all different puzzle pieces and how they fit together to create a personalized care team for this family. Some babies might need everyone. Okay, depending like what was when were they born? Were they born prematurely? Were they on a CPAP? What was the birth trauma? Was there shoulder dystocia? How long were in the canal? So some babies might need a whole actual team of different support. Some babies might just need a lactation specialist and just me. Okay. So you have to create different care plans on what's going on for that specific baby and that family's need at that time. For me, again, I really stress to families, I'm the anatomical side. I can release anything that I see. But for me, the outcome of my procedure is not how a new frenulum heals. The outcome of my procedures of what makes it successful is what's the progress of functionality. Are we getting improvement in that mobility? Are we seeing more regulation? Are we seeing less spit up? Okay. And we have to be mindful again, you have to give these babies time and grace to really show you those changes. That's why I stress 6 to 8 weeks post-procedure date is when you would see more consistency. That's the reason why I also do a 1 week follow-up and a 2 week follow-up to help assess the wound healing. And at the second follow-up, create a new care plan. What progress have you made? Families, I believe in patient autonomy. If they don't want to see a body worker or chiropractor, I've done red light therapy on these babes and I'm still seeing tension. I'm like, okay, then I think it's time to create a new care plan and maybe finally see a body worker to help relieve any of that tension or asymmetries going on in the body to help during the contraction phase of wound healing. Okay. This is my analogy of a tongue tie. Like if I was born with my shoelaces tied together, I could be a racetrack runner. I'm not going to be very good. I'm not going to be very efficient. I could shuffle my feet. I might trip and fall. It might take me 30 to 30 minutes or so. But once my shoelaces are released and I have good range of motion in my feet, I can't just go sprinting right away. My muscles and body don't know what to do with that new mobility. So I need to give myself time and grace to, strengthen, tone, and coordinate these muscles so I get faster, more efficient around the racetrack over time. That's analogy of a tongue tie. Okay. So for me, individual talents get magnified many times over through the collective lens of an effective team. This was my first, my second more mini in-network event that I held. And so again, many amazing providers there. Really create and really search for your care team. Okay. Interview these doctors. Don't hesitate to ask them questions. We need that model to change for sure. I invite families or whoever to ask me questions about my training. We should be doing the same thing to these pediatricians that are gaslighting families. We should be doing the same thing to any doctor who's doing a release procedure. And what are they using? What are their follow-up protocols? Are they teaching wound care stretches? Do you have a collaborative care team of people? Do you work with other providers? And could you give me some recommendations of other providers you work with? I think that could speak volumes of what kind of doctor, if it's just a doctor just does the procedures, or a doctor who's truly invested in really helping these families, creating a collaborative care team to get the best functional outcome. So especially interview your colleagues, an occupational therapist, physical therapist, see what training they have. What is their care plan when they're preparing a family for a release procedure? I got to know different chiropractors and I asked them, what are their protocols? Some chiropractors, just, once a month, you're good, things like that. I'm like, that's not how it works with the babies I see. Sometimes these babies might need to be seen once a week, and definitely after the procedure itself. It's like, I definitely understand they get how the release impacts the whole body. Okay. Honestly, the tools for the frenectomy does matter. It's been said that it's the skills of the provider that matters. And, I do disagree with that. We have amazing technology. Why not use the best technology out there to get a very precise, very conservative, and very safe release done? A lot of doctors, yeah, they're still using surgical scissors, cold steel, they'll call it. I had a cute ENT that was actually at a tongue tie course, and he was like maybe in his 70s. And he's just so cute that he wants to learn right now. He's like, oh yeah, like you guys on lasers, like this is amazing. I just use cold steel, but maybe I'll look into getting one. And I was like, I love that he was still thinking about that at his age, even though he's like, I'm close to retirement, but he's like, I need to start understanding like what better tools can I use for my procedures. And so usually most of the time, it seems like with my experience of babies I've seen who had initial release done by scissors, it's incomplete. It's very incomplete. You're literally just maybe just doing a tiny snip. A lot of these doctors don't know what their stopping point is. With the scissors, it does tend to have a lot more bleeding. Okay. There are some tiny blood vessels that do cross over into those areas of those tissues, where with my COT laser, what it does, it really helps like ablate everything. It really helps minimize the bleeding. It really allows me to get very nice, precise incisions layer by layer very quickly and very efficiently. Hopefully this video plays. I really hope it does. These are amazing videos from Dr. Richard Baxter. He's the one that wrote the tongue tie book. He has the same laser that I have. I just can't get great videos like he does. So I hope this plays. If not, I could send you guys links later. but this is a lip release. Hopefully you guys can see that. Just see how minimal the bleeding is, how fast and gentle it is on those tissues when you're doing a release with that laser. Guarantee with the scissors, you guys are going to see a lot of bleeding. Here's the tongue. He uses his hands a lot. I don't like to use my hands. I use something called a groove director to help me elevate the tissues better. You really need to make sure that when you're doing the release, you're making those tissues taut, very tight, so you know exactly where you're making your incision at. But no bleeding at all, you guys. Very, very minimal bleeding. Here's another one, and tongue tie release. That's a lot faster. Done. Beautiful, clean to the genial glossus fascial area. Very, very clean. Okay. There are different lasers on the market. The one that I use is a CO2 laser. What it gently does is that it gently heats up the water molecules to allow me to make a nice clean incision. Where there's other lasers, such as diode lasers, they're basically like a hot tip. Okay. My mentor, Dr. Pinto, had good videos of her when she was first using a diode before she switched to the CO2 laser, and she did a comparison of how fast it took her. And I don't like describing it this way, but with a diode laser, it's like having a dull knife and really cutting into like, really thick piece of meat. It took a long, long time, like 30 seconds to release versus like under 10 to 5 seconds. Okay. We get in, we get out, we bring baby back. We're very gentle on the tissues, and you just want them to get nice, calm, and regulated with who they love and know, which is their mom. Okay. Or their dad, whoever's there. Just a little bit about how I practice. Most of us providers, regardless of his dentist, OT, a lot of us do introductory phone calls so they understand exactly what we're doing and like how we're doing it, and just general questions, really. Okay. For me, my consultations, because this is all I literally do, is just focus on tongue ties, lip ties, cheek ties, and creating a collaborative care team for the families. My consultations are always 16 minutes. Families always get my cell number if they have any questions after the consultation too, as well. If they have any questions about their care plan, they definitely did. Families deserve to be heard and supported, feel safe, and just really they need to be given the autonomy. And there are different treatment options. If I diagnose restrictions and the family's like, we don't want to do it, okay, great. Let's create a care plan then to help at least optimize functionality at the limited mobility that your baby has. You'll be able to hopefully maybe improve a little bit, but then you're just going to plateau. And if that's what makes them comfortable at that time, then we need to support that functionality. There's always different care plans that you guys could give to these families. Let's see. Most providers of who do what I do, okay, more local ones I know. On a professional Facebook group, I was surprised a lot of doctors out of state don't put a little numbing gel underneath the tongue or lips wherever they're doing the procedure. I believe in pain management. It's a very safe numbing gel. It's 2.5% lidocaine, 2.5% tetracaine. It is not benzocaine, which is what was taken off the shelves because that can cause methylglobulinemia if a lot of babies tend to swallow that. That was like in the teething gel that was just being sold over the counters. So completely different. This numbing gel that gets formulated, Dr. Pinto uses it too as well. Is very fast acting, very short lived. My husband's a dentist, so of course when I started doing this and we tried it on each other, it works very, very well. I have to hide it from him in the office because it works very well, so he could use the other stuff for his families. But I think placing the numbing gel also brings comfort to the families too, knowing that there is some pain management that's not going to last very long. Families for me are waiting in the consultation room. I want families to get ready to either feed their baby or soothe their baby however way they want to. I don't think I've ever had a family come with me in the consultation room because I've seen other doctors who do that, and it really is hard on the mom's heart. So I'm like, I also need to focus on the baby and not the mom. Okay. But I tell families they're with me for a couple minutes, but it's very quick. The procedure itself is just a couple seconds. And you can see right here in the photo, we take immediate photos right afterwards to show the full release and swallow them, bring them directly back to you to feed, soothe, comfort, however way you want to do it. So I definitely had moms feed in different ways. I know I didn't get like a breastfeeding picture, but have a lactation specialist right here helping this dad who came by himself with the baby feed with the bottle. This mom feeding on the bottle. This mom was actually syringe feeding initially right afterwards. Okay. Then we go into wound care. Wound care is very, very important. The I do it on the family so they know exactly what to expect of how it feels and the motion of it. That's why I tend that is more fearful for families is that they don't exactly know what to do if they're doing it correctly. So I do it on every single family member. They record me doing the wound care stretches, and then they record me doing the wound care stretches, and then they glove up and do it with me. For this family, this grandma, she wanted to do it because she's helping out her mom. Her daughter. And so, yeah, I did the wound care stretch on the grandma. The grandma was getting in there, and I was watching the finger motion of what she was doing. Okay. So it's really important to really help these families with those wound care stretches. And I love it when lactation specialists, OTs, chiropractors, when they know exactly what they're looking at for the wound and healing, or know how to do wound care stretches. It brings them comfort when they see you a couple days afterwards. I always stress lactation no matter what after the release procedure, whether that's with an IBCLC or your feeding therapist, like an occupational therapist. Their mobility is different now, so they need that feeding support. Okay. The wound care video that I have will not download. I'll send Faith some links of the wound care videos that I have. I do have wound care videos on my website. Two of them are a little outdated, but the positioning isn't. What I used to do with my wound care stretches is that pretend this is the tongue, this is where the wound is at. I used to do 3 to 4 push scoop lifts. Okay, but I switched it up. I switched it up to 2 push, scoop, lift, and hold up. Okay, your fingers going on the top part of the diamond because you want to get that good stretch. You really, really want to make sure that you're separating those tissues. And I'll show you guys my wound care handout. I think I could be able to switch over to that real quickly. Actually, let me see. Let's see, share a different screen. Let me see. Can I go to screen 1? Can you guys see my wound care handout? Yes? Okay. So this is a wound care handout I give to families. I'm happy to also give it to Faith so she could give it to you guys, but just be mindful. Whatever doctor that you're working with, please just stick to their protocols. You're definitely welcome to share this with other families if you want, but it's going to be different. And we just don't really want to confuse those families either. Okay. But this is what families can expect when they see me. I share with families, within 24 hours, they're going to get some sort of white healing patch. Okay. It's not infection. Never had any babies that had infection. If it becomes yellow, that's not an infection. If the baby had jaundice, yeah, that bilirubin might be still floating around and everything. I share with families, you're going to get some sort of open diamond wound. Okay. And I outlined the diamond wound in 2 different colors to explain it. When the tongue is at rest, at the arrows, the wound is folded in half. So we don't do any wound care stretches to help guide the way that the new frenulum heals, which is taller, farther back towards the muscle or higher up into the lip. And we want more flexibility. If we don't do anything to help guide that wound healing, basically the new frenulum is going to heal tighter to where we initially started. So we do have to do daily wound care stretches at least 3 to 4 times a day. The ideal goal is that you're separating the top orange from the bottom blue. Okay. And so definitely more in details, and I really go over this with families. When you're doing the wound care stretch, you are gently separating it. There are some families that I do the forklift maneuver where you're just lifting it up. But my concern with the forklift maneuver is I see families not lift, they push back. And when they push back that tongue, you're basically folding the tongue in half where these arrows are at and getting stickiness of the wounds. I don't like to use a term reattachment. They get sticky. Okay. The wound is very sticky. They're going to stick to each other just like any cut. You put a band-aid on top of it, you peel it off. Sometimes that open wound is going to stick to that gauzy part. Okay. So we want to really help decrease the amount of stickiness to that wound. And if there is any stickiness, that's why we do a 1 week follow-up to help do a wound care stretch for the families and to help unstick any areas that are sticking and to help re-guide the way that that new frenulum is going to heal. Okay. So it just depends. Some families, it was better for them to do the forklift. So we switched to that. But when the family showed me the forklift maneuver, they're really pushing it back and folding it in half. So your really ideal goal is that the new frenulum will heal similar to the wound that I made, which is that tall open diamond. Okay. Comfort recommendations. Really, my recommendations for comfort is really just gentle comfort and any homeopathics. There was a paper that came out this year that said maybe Tylenol works 50% of the time for these younger babies. I do tell families personally, I'm a little crunchy myself, and I'm like, why do I need to get that medication? Really just gentle comfort and like homeopathics are very, very helpful and useful for these babies. There was only one babe that I said, yes, you need to give Tylenol. It was a very, 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 very thick lip tie that I've ever released. The lip is definitely going to be more sensitive to the tongue because there's more nerves up in this area. And so it was only one time I ever recommended to do that. And then healing with light therapy, which is coming up. I'll discuss a little bit about that, but that's my wound care handout. That's how basically I do my wound care with families. I talk a lot about healing stages, okay, because babies are more sensitive to the wound healing stages. So especially when families ask when do they get fussy, I do recommend that, like, hey, not recommend, but they do get fussy maybe 4 to 5 hours post procedure, but peak fussiness is usually when peak inflammation occurs, which is about 1 to 3 days after the procedure. Okay, so I really stress that because babies are more sensitive to these wound healing stages. And same thing, like, is it normal, things like that, just comforting mom to understand, like, the healing stages of what we go through. And especially, after 2 weeks of doing wound care stretches, I do have families do gentle massaging of the tissues for 4 weeks afterwards. It's supposed to be more fun and passive because you have to realize that these new layers of tissue healed, and we're going to go into the wound contraction phase. And sometimes these babies during the wound contraction phase can see a little bit of that sensitivity to their function and feeding. So that's why I tell families it's normal when you're doing these gentle massages. You might feel the tissues feel tighter one day than the other. That's not reattachment. It's a contraction of these tissues occurring due to natural wound healing stages of the body. And so we know that this can go on about 2 to 3 weeks post surgery. Okay. And that, even over time, maturation and remodeling of these tissues, okay, will occur so many months afterwards. That what we do know is that the new tissues in frenulum will soften up over time. That's why when it comes to, oh my gosh, should we do another release right now? Things like that. I respect the natural wound healing stages. And it's like, well, what are we going to do differently to get a better outcome of a second release that we didn't do before the first release? Okay. So I'm not too eager to just rush into it right away, because again, if you do a second release too soon, you're causing more scar tissue to occur. And that could even heal thicker and tighter. And again, impact the mobility and impact functionality. Let's see. I know we're running out of time, but I just want to show you guys that this babe that I saw, you can see just this was the initial intake forms, of what I give to families. This baby was born at 24 weeks gestation. So I saw them after they got out of the NICU. They were working with many OTs and everything, and mom really wanted to breastfeed. They did their son's release a lot older, but of course that son wasn't in NICU, so it's a different experience. And so she actually drove out from San Diego to see me. And then this is the before questionnaire. And then this is at the 2-week follow-up that you can see at the second follow-up. A lot of these don't occur anymore. Okay, this is how I gauge what's going on and what new care plan I need to make for families. Okay, and then of course, this is This is a side by side of the initial consultation, and this is like the second one. So you can see a lot of these were sometimes yes, 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 and now it's like does not occur anymore. They're improving is an answer, so we know we're on the right path of what we're looking at. Same thing with the mom. She was at a moderate discomfort. Now she's at a 0. It's really great to see like their changes too of what they're seeing. So these are like snapshots of the release. She didn't come in for the second one. We just did a virtual one, but she filled out the intake form for me at least. But with the first follow-up, everything was healing very, very nicely. Light, I hope this doesn't freeze. So I do light therapy in my office. I recently just got this. And so with light therapy, I love to use it at consultations if we're not doing a release, or if it's not necessary to do a release. It at least helps reduce inflammation, provides more flexibility to the body and to the tissues and into the head and neck area. Let me get out of this. Go to the next slide. Okay, so what healing light therapy does is that at different wavelengths is targeting the cells to help bring in more circulation, to bring more oxygen, to help get the cells to create more ATP and energy to just really enhance wound healing. And with this light therapy, it helps reduce inflammation, and we know it provides some analgesics. Okay, so it's very, very gentle. Where with my protocols of what I've learned is that like we're doing the head, neck, and jaw area, and then we're also going inside the mouth. And depending on each follow-up, okay, sometimes I'll do light therapy and sometimes we won't. Just depends on how things are healing and how things are tightening or not tight. What was interesting, I didn't have time to put it on my presentation, but there's a baby that was a Curl's 4, and I was like, wow, great, okay, let's do OT, create a whole care plan with them. And they said that, hey, after you did light therapy at the consultation, we noticed a little bit more relaxation. And the chiropractor that we're working with really suggests that we continue light therapy with you. So I'm like, yeah, let's do it. So we did 3 sessions of light therapy afterwards while they were working with an occupational therapist with oral motor exercises and feeding support. They're working with a chiropractor who also knows some craniosacral therapy too as well. And then they saw improvements, but then they still had a lot of issues and concerns going on. And they rechecked an anatomy, and I was like, wow, doing all this preparatory work actually really defined the anatomy that was not there before we did all these interventions. So doing all this prep work actually helps the release provider too as well to know like, hey, like, yeah, it seems like we do need to release this. And it really defines exactly where I'm going to go to be more precise. Okay. Let's see. We went over wound care handout. So I know we're running out of time, but in summary, I hope this was more information that you guys were seeking for. I really, really stress lactation support as soon as possible, and not just one, but multiple times, especially if you guys are able to give that care. Even if it's like a virtual or a text, families really do need that constant, touch to know that they're on the right path of everything. Really get to know your care team, really interview the people that you want to refer to and work with, and definitely create that care team for your families and find the right doctors in your area who are doing it in the most gentle ways possible. Okay. And so just remember that releasing the tie is just one part of the puzzle piece. It does take a collaborative care team for proper functional assessment, diagnosing, treatment, and care to just really get the best overall functional outcome. For me, what I always say, we want to do a frenectomy procedure the right way and not the rushed way. Okay. So we really need to stress with families, depending on what's going on, and we're putting everything together, that yes, sometimes certain situations, we do have time to work on this if the family's up for it. Okay. So yeah, that is it, you guys. I hope that was really helpful.